When we look at sodium, is that the sodium in your blood is dependent on how much water you have in your body. This is the only electrolyte that cares about water. No other electrolyte is affected as much as sodium. The body fluids, you got to remember that sodium is largely responsible for osmolality of vascular fluids. Double in sodium gives the approximate serum osmolality if you look on a lab result. And then your sodium can shift into the cells and potassium shifts out of the cells. And this is done repeatedly to maintain water balance and neuromuscular activity. It is important for neuromuscularly that sodium is for transmission and conduction of the nerve impulses. When we look at the acid-base balance, sodium combines readily with chloride or bicarbonate to regulate the acid-base balance. If the amount of fluid in your body is low, you may have fluid loss due to excessive sweat and diarrhea, use of diuretics, or burns. If your total body water is normal, high sodium levels may be due to diabetes insipidus or too little of the hormone vasopressin. If your total body water is high, this may indicate hyperaldosteronism, Cushing syndrome, or a diet that's too high in salt or sodium bicarbonate. For hypernatremia, this is the same thing as being dehydrated. Common causes are inadequate intake of water, which is typically going to be in the elderly or disabled patients who are unable to take in water as their thirst dictates. This is probably the most common cause. Excessive losses of water from the urinary tract may be caused by glycosuria or other osmotic diuretics. Water losses associated with extreme sweating could also happen, or severe watery diarrhea. The intake of hypertonic fluid, which is a fluid with a higher concentration of solutes than the remainder of the body, and this is relatively uncommon, though it can occur after a vigorous resuscitation when a patient receives a large volume of concentrated sodium bicarbonate solution. Ingesting seawater also causes hypernatremia because seawater is hypertonic. A high sodium level, again, is usually caused by dehydration or use of diuretics. Most potassium intake is acquired through the diet. Renal failure can lead to potassium problems, and the potassium plays a vital role in cell metabolism and cardiac and neuromuscular function. Potassium is secreted by the kidneys, and if the kidneys are not working well, the serum potassium will go up. Aldactone, which is a potassium-sparing diuretic, can also make your potassium go up. Now, the kidneys are the principal organ for eliminating potassium. Hyperkalemia is an excess of potassium in the blood, and it can cause cardiac arrhythmias and cardiac arrest. You would see an elevated T wave, which would be present in an ECG of a patient with hyperkalemia. Also, muscle weakness is a symptom. People with high potassium levels must stop eating potassium-rich foods and stop taking potassium supplements. They're usually given a medication like diuretics to help reduce the amount of potassium in the body. Treatment of hyperkalemia includes IV administration of glucose and insulin, and it helps lower potassium levels. Sodium bicarbonate also causes the potassium to shift into the cells. Insulin carries glucose and potassium into the cells and carries the sugar out of the vascular space, and that makes your blood sugar drop. K-exolate exchanges the sodium or potassium in the GI tract, and sodium and potassium have that inverse relationship. So if you're driving the sodium in, well, that's going to get the potassium down. But you got to be careful. If you're trying to make their potassium go down, it could drive their sodium up and make the patient dehydrated. Now, the last treatment would be dialysis because the kidneys are not working, and this is removal of excess potassium by the kidneys or by hemodialysis. You also consider hyperkalemia as a potential cause in a cardiac arrest in a patient with renal impairment or renal failure. And that first symptom of a high potassium level may be an abnormal heart rhythm. Hypocalcemia. Now, there's many causes of low potassium. Too much or depleted magnesium can cause low calcium. Also, prolonged use of medications and laxatives that contain magnesium. The signs and symptoms are tetany, which is a repetitive neuromuscular discharge seen in severe hypocalcemia. A milder form of neuromuscular irritability are paresthesias and numbness of the fingertips and twitching of the facial muscles over the cranial nerve 2 at the ear, and this is known as Shafostak sign. Trousseau's sign consists of carpal spasm provoked by ischemia, and it's induced by inflation of the blood pressure cuff around the arm. Spontaneous muscle cramps are commonly seen in hypocalcemia, and prolonged contraction of the respiratory and laryngeal muscles can cause stertorous breathing and can cause cyanosis. And treatment does include IV calcium. Magnesium helps maintain normal muscle and nerve function. It helps heart rhythm steady, supports a healthy immune system, and helps keep bones strong. Magnesium also helps regulate blood sugar levels, promotes normal blood pressure, and is known to be involved in energy metabolism and protein synthesis. There is an increased interest in the role of magnesium in preventing and managing disorders like hypertension, cardiovascular disease, and diabetes. And dietary magnesium is absorbed in the small intestine, and magnesium is excreted through the kidneys. A high magnesium could also cause renal failure, dehydration, diabetic acidosis. The kidneys do not work and the body is unable to get rid of magnesium, and it will begin to build up in the bloodstream. Antacids have magnesium in it, and so magnesium makes the vessels vasodilate, which makes your blood pressure come down. The treatment is if the respirations fall below 12, the patient may be put on a ventilator, and they may be put on dialysis because the kidneys are not working. Causes of low phosphorus is common in patients withdrawn from alcohol and in patients undergoing treatment for diabetic ketoacidosis. Other risk factors would include a chronic ingestion of phosphate-binding antacids, patients who are on TPN or with an inadequate phosphate supplementation, or for those patients who are refed after prolonged starvation, like an anorexic nervosa patient. The signs and symptoms will see the muscle weakness is the most common physical finding, and careful assessment of their motor strength on neuroexam is critical. The weakness may be subtle or it could be profound and involve any muscle group. Diminished respiratory rate and tidal volume could reflect a respiratory impairment due to a low phosphorus. They could also be tachypnic. An important clue to one of the most common etiologies of a low phosphorus is respiratory alkalosis. Hypertension and cardiac compromise could be due to a severe low phosphorus as well. The treatment is twofold. Correct any precipitating cause of the low phosphorus and replace total body phosphates. But depending on the clinical situation, the replacement options include dietary phosphates and oral phosphate preparations or IV phosphate. Low phosphate and low potassium can coexist in certain disorders like diabetic ketoacidosis and alcoholism, so replacement with potassium would be appropriate.